Good afternoon. Welcome to Medical Grand Rounds. Today is another COVID Grand Rounds, and very excited to have an opportunity to chat with Eric Topple. Let me give you the ground rules first before we bring Eric on. There they are. You know these by now. Zoom in full screen mode. I'm going to stop saying that. I think if you don't know how to use Zoom by now, we got a big problem. If you have questions, type in the Q&A box. I'll try to get to some of them. The session will be recorded and posted on YouTube tonight. Our overall, I think we've had over 3 million views from our Grand Rounds over the past couple of years. Closed captioning is available. And if you want CME, stay on at the end of the session, and instructions and the barcode will be given to you at that point. So without further ado, let me turn to our special guest. So Eric Topple is founder and director of the Scripps Research Translational Institute and senior consultant at the Division of Cardiovascular Diseases at the Scripps Clinic in La Jolla, California. He's got a long and incredibly impressive bio, but I'll do the most important part first. He was a medicine resident at UCSF. He's also editor-in-chief of Medscape and theheart.org. He's published 3 best-selling books on the future of medicine. Highly recommended to any of you interested in the future of medicine. I hope you all are. In 2018-19, he led a commission for the National Health Service in the UK, looking at their future workforce, genomics, digital medicine, AI. He's been principal investigator on grants totaling at least $250 million, including leading a significant part of the NIH's All of Us Precision Medicine Initiative. He's a member of the ASCI, the AAP, the National Academy of Medicine. In 2012, Modern Healthcare magazine deemed him the most influential physician executive in the United States. Since COVID began, his Twitter feed has become an essential resource for individuals who want to follow the pandemic, and particularly emerging literature. Eric has tweeted out anything that happens that's new and important. Within minutes, Eric seems to have it up, and 600,000 followers have recognized that. And I've told people that if you were stuck on a desert island and could follow only one person in COVID, Eric would be the person. So Eric, why don't you come on? Welcome. It's great to have you here. So I'm going to do a COVID sandwich. We're going to start with a couple of kind of personal questions. Then it's going to be pretty much all COVID, which is what I assume most folks want to hear about. And then a couple of questions at the end about kind of the future of medicine and what this leaves us with after, hopefully, this thing goes away. So let's start with a personal question, which is it's admission season. We may have some applicants to our residency watching, and I'd love you to sort of reflect on your experience at UCSF as a resident and what it meant to you and your career.
Bob, first, let me just say it's terrific to be with you, and thanks so much for your kind intro. As far as UCSF, I think you know I have an incredibly fond memory of my 3 years back in ancient times, 1979 to 1982, under the leadership of Holly Smith and the inspiration of Kanu Chatterjee that totally shaped my career. Those 3 years were probably one of the 3 of the best years of my life. We had our first baby. My wife worked at the time Mount Zion as a midwife, and that time was just hard to replace over all the other times I've had, all the other phases of my career. So I don't know that there's a better UCSF residency than UCSF medicine in the world. I have recommended it throughout. If you can get in, I know it's highly competitive. Remember, of particular note, I don't know how it stands now, but at Moffitt, I don't know if it's still called Moffitt.
Still called Moffitt.
Okay, 23 admissions one night. That was, I got a lot of ribbing about it. That was very long a night. And of course, it's pretty hard to do full workups on 23 people. But overall, amazing experience. And between the 3 places with the county and the VA, just phenomenal.
Oh, great. Thank you. Yeah, with 23 admissions to an individual we don't allow anymore. So you'll be pleased to hear. Let's talk just for a second about your Twitter feed. So I know you've been tweeting for a long time, but clearly when COVID started, you began to be quite prolific. And in some ways, your lane is these extraordinary, detailed, annotated, up to the minute tweets that capture what's going on in the literature, and everybody's dependent on these. And you tweeted last night, like people ask you like about your team, and it sounds like we're looking at it. You are it. So what made you want to do that, and how's that experience been for you?
Yeah, well, just to say from yesterday, I was on the line with Carl Zimmer about a piece he's working on for the New York Times, and he asked me, "Tell me about your team that helps you with Twitter." I said, "What do you mean team?" And it has been a recurrent theme of questions. So for the 12 years that I've been on, I think what team? I mean, whether reading the articles, whether it's making the graphs or analyses, it's something that I enjoy doing. Is sharing, and if we all shared more, we'd all get smarter faster. So I've taken to Twitter. Obviously, it can be vicious and bad, and there are bad days when there's ad hominem attacks and all kinds of made up stuff. But overall, I think there's a net benefit, and I think it's been great for the pandemic in terms of exchanging new information, ideas. I wish it was more collegial. I wish it was something that was better than it is right now. But overall, kind of like everything in medicine, there's a net benefit.
Yeah, good. Yeah, I see it exactly the same way. So thank you for that, and keep it up. Let's start into COVID. Maybe just give us this will be very open-ended. We'll drill down to specifics as we go on, but your big picture assessment of where we find ourselves today.
Right. Well, clearly you've been a real leader in this as well, Bob. So, these are very complementary views as yours and many others. But, I think what the real situation we're in right now is we have this maybe warped view about how mild or milder Omicron is, when it clearly can kill and put a lot of people in the hospital. And I was really impressed with the Washington Post op-ed that you and your colleagues published last weekend regarding this classification of for and with the hospitalizations, because it's a blurred line, and too many have tried to minimize the hospitalizations, which are now well over 150,000 that are due to COVID one way or another. And I think we are grossly overestimating the with rather than the for COVID. But the main thing here is we've got to get through this phase. This is a version of the virus that has remarkable antigenic drift from where we were with the prior versions. So that is a challenge. We hope that we were seeing some early signs that we're going to get on this descent. There's only a few countries besides South Africa that have had that descent so far: the UK, Ireland, and what was the third one? I'm trying to remember. I saw this noted last night. So it's early, and I hope that what we're seeing perhaps in New York City, DC, Maryland, sounds like Northern California from the wastewater data that you just posted, Boston, maybe this is the encouraging signs that we're going to get through this descent the next few weeks. But there's a lot of parts of the country that are much more vulnerable than the ones that have been first exposed. We haven't seen it get into places that are much lower vaccination rates, much lower booster rates, much lower children vaccination rates. That's what I'm worried about in the weeks ahead. Once we get through that phase, sometime hopefully in February, then we'll have a better sense of whether we're moving towards some containment or is it just a lull before a second Omicron wave or yet another Greek letter variant.
Mm-hmm. Do we fully understand why it comes down so fast? And the prior surges have also come down not as quickly, but is it just that you hit a level of immunity that's different, or is there something about this that is that we don't quite get?
I think it's the latter, Bob. It's something we don't quite get. Any speculation about why the descent is seemingly similar to the ascent and its abruptness isn't backed up by any data at this point. So it's one of the mysteries. there are a few mysteries about Omicron. The other one, I think, right up high on the list is about the transmissibility. We know it's principally driven by the immune escape. And a recent study from Isabel Eckerle and colleagues showed that the viral load isn't nearly as high as was originally the 70-fold increase in upper airway viral load that the Hong Kong medical group had put out, University of Hong Kong School of Medicine. So we don't really understand the transmissibility, the contagiousness, if you will, beyond the fact that the immune escape, and it's just extraordinary. I mean, these are vertical lines I call the O sign that we've never seen and hopefully we'll never see again. I don't know how you can exceed it unless you go into a log plot, because linear plots couldn't be worse than where we are now. So I think those are the two biggest biologic mysteries here is, number one, why is there such rapid descent? And secondly, how do you explain this hypertransmissibility? Because immune escape only, it can get you pretty far, but this is extraordinary.
I've sort of gone with, maybe this is wrong, that the infective dose, that the amount of virus I need to hit my nose or my mouth is substantially lower because it sort of burrows in better and sets its up shop better. Is there evidence that support? And it sort of gets to a parallel question I was asked today and couldn't really answer. The things that we deemed to be safe before, outside, none of us are cleaning the mail anymore. Should we be rethinking those because of its incredible infectivity, or are those still reasonable rules of thumb that you're not going to get it from touching something, you're not going to get it from breathing air outside?
Yeah, really good questions, of course, coming from you. So I think the issue about rebooting some of our practices that we had abandoned, like outdoors or fomites, surfaces. I'm a little concerned about outdoor transmission when you have something that's just so transmissible and we don't really fully understand why. I thought it was going to be easy when we first started seeing a few reports about this upper airway, much higher viral loads, which has now been challenged. So it's not entirely clear. But I think it is still true that, as you say, the ability to get into cells of upper airway, particularly nasal mucosa, oral mucosa, is that hasn't been challenged. It's just a matter of this, exceedingly high viral load. So you're probably right as to how it gets in so easily, and as you say, burrows with this facilitated immune escape that we just basically don't see it, our immune recognition. And interestingly, I think the outdoor transmission, which is still probably fine, but I think why not wear a mask, just because we don't know. And I think this is the other issue that is the inevitability camp that thinks, oh, well, so what? I think that needs to be debunked. That is obviously not the right answer. So people are thinking somehow, maybe they're not saying it, but getting Omicron is like getting a live attenuated virus vaccine. And that could be further from the truth.
Well, let's deconstruct that. So the inevitability camp, I think, is sort of shorthand for we're all going to get it, so why even bother trying? And then there's sort of the next sentence is, and this is sort of my way of getting either a vaccine or a booster. Let's sort of talk about the inevitability. I don't think I've had COVID yet. I'm trying my darndest not to get it for the next 3 weeks or a month. That it sounds like that's where you are as well. You still feel like it's not inevitable that everybody's going to get it. I think Fauci may have confused things a little bit. It probably is inevitable you're going to be exposed to it unless you're hiding under your kitchen table, but it's not inevitable you're going to get it. Is that where you have landed?
Absolutely. I think it was unfortunate when both Janet Woodcock and Tony made comments about, most people are going to get it or everyone's going to get it, because that kind of really fosters the sense of inevitability. We don't want that. We actually don't even want to be exposed, ideally, right? So I think the idea is, and you put it really well there, is get through these next few weeks where there's such high circulating virus, then regroup. But let's not invite an unpredictable virus. It can cause long COVID. There's some rationale why that would be a concern. It can cause secondary attacks to people who are immunocompromised, unwittingly getting somebody very sick, even if you are not in some high-risk group. I think the idea of this inevitability, we want to move away from that and protect everyone, protect ourselves.
And speaking of debunking, you came down, as did many other people in the know, on an editorial in the Wall Street Journal the other day that I'd say already pushed the button there, that made the point that somehow everybody just getting it is really good because it'll help prevent variants. So why don't you tackle that one?
Well, that was amazing to me. In fact, I almost was tweetless. That was a new.
Wow.
So incredibly stunned by this that this couple could publish, and the Wall Street Journal would publish. I mean, I guess in light of other things they put on their editorial page, I shouldn't be surprised. But here, basically the exact opposite of everything. It's like turning the world upside down about the pandemic and saying that essentially we should have chickenpox parties and speed the spread. Can you imagine speed the spread? They acknowledge that there may be a little risk involved.
That's nice.
That will be the way to preempt variants. I mean, help me. The whole idea is that we don't want to cultivate more variants. That's why we, do things like try to avoid overwhelming medical resources and overwhelming the cultivation of infections. I mean, my goodness, this to go here in January 22, our third year of the pandemic, to reach something like this, it was just extraordinary.
Yeah, wow. Almost tweetless. I hadn't heard that term before. I like that.
I never made it. Yeah.
All right, let's pivot to testing, which is complicated and messy and beset also by shortages and to some extent gotten politicized like everything else. So we'll just kind of talk us through kind of what you think about the role of testing now. There was some early reports that maybe rapid tests don't work as well against Omicron, and then some of our colleagues here just published a really important paper showing that it did seem to work as well. So how are you, we'll get to the isolation guidelines and the day 5 issue after that, but just talk about sort of how you were thinking about testing today.
Yeah, I'm into the rapid tests, and I haven't seen any convincing data that they don't work well. The UCSF report and others since then have all reinforced that their performance is quite reasonable. They're not perfect. And as I think people know, you need to have multiple tests to be more assured. You need to be testing, very proximal in time to a gathering if you want to really get the right readout. There are differences between these rapid tests. But, I think, like, for example, today, the UK, England specifically changed their isolation period to 5 days, but that's with 2 days of a rapid test. And they have had that practice of 2 days consecutive being negative before getting out of isolation. And that's the best practices of all the countries that have been relying on rapid tests. We're the only major country that hasn't had rapid tests and has had a cockamamie idea that was put forth that we should stop isolation in 5 days without a test of any kind and just wear a mask of any kind. That to me was one of the real low points of our CDC, unfortunately.
So your feeling is that UK or England at least has gotten it right, that at 5 days test, and if you're negative and you're asymptomatic or your symptoms are better, it's okay for you to go out, but you should be wearing a good mask. If you're positive, you stay in until you're negative for 2 days. Is that how you think about it?
They had a very important paper, preprint this past week that if you're at 5 days, a third of people are still going to be positive. Right. So like your son, I think, right?
Yeah, he's still positive on day 7. I tweeted last night, I love him dearly, but I wouldn't want him to breathe on me. And I've gotten a lot of, you talk about the Twitter blowback, I've gotten a lot of blowback today about what a terrible parent I am. So I'm still reeling from that, but I'm trying to get through this.
Let me say, I couldn't be further from the truth. Okay. But as far as, it is mostly at day 7, day 8, when people turn negative. So day 5 is pushing. But so what the UK has done, just like, many other countries throughout Europe and in Asia, is 2 days of negative tests, and typically, day 5 is early. So for the CDC to recommend this with no evidence, knowing best practices of other countries, I hope they know them, that promotes spread. That's the kind of the opposite of what they're supposed to be doing here.
Yeah.
But I think the rapid tests should not be undermined by some, what I would consider very scant, small numbers of people where, this charge of reduced sensitivity. We've all known, and Michael Mina has led this, for the whole course of the pandemic, that relying on just one result when you're trying to make a call about isolation isn't ideal. And that's why, I really think they're important. I wish we had the supply situation remedied a long time ago. Just like when we called for the KN95 and N95 masks that be supplied to everyone, rapid tests. Here it is, more than a year later, and finally these things are starting to happen, but of course, much too late.
And what do you think happened? I think both of us know a lot of the people in the administration, they're smart and they're good. Is it your sense that they just put all their eggs in the vaccine basket? They figured the vaccines would get us out of this mess and we don't have to think very much about masking and testing and all those things? Is that sort of what went on?
Well, it's hard to make it as a real dichotomous decision, but clearly they were leaning that let's bet big on the vaccines and de-emphasize the others. So there were many things that were de-emphasized. So not just the fact that the rapid tests, we shouldn't, get them and distribute them, that we shouldn't. Another one that was a big one, Bob, was about the Paxilvid story. So, my understanding is that Pfizer, Merck, and Roche, the three big pill companies that were going into testing, by that point, late phase testing, they approached the administration to say, would you like to put in, big orders for Paxilvid, which turned out to be we don't know about the Roche drug, and the Merck drug has, a lot of questions about it. But Paxilvid is an exciting, and I believe the second most important advance as far as after vaccines in the pandemic, yet we don't have it, essentially. So they were asked to put in an order and they declined. The reason for that decline was, I guess, two things. One is the big bet on vaccines and the fact that this wasn't proven yet. There hadn't been, the 2 phase 3 trials that ultimately were done recently. So you could say, well, they made a big bet on vaccines with Operation Warp Speed, but they weren't willing to make other big bets. And certainly getting rapid tests, I envisioned back in 2020 that distribution of really high quality masks with USA on every mask would be a way to build spirit and patriotism, something we don't really have as far as the divisiveness. But we haven't used some of the other tools that we could have to help us get through this. And the biggest one to me is the lack of data navigation, the lack of data capture.
I'm going to get back to that in a second. Let me finish with testing. One last question. Your read of the evidence in terms of the throat plus the nose alone, the throat alone. If you were testing yourself or a loved one today, what technique would you use?
Yeah, I'm not sure about that one. I think the anecdotes are very supportive. I'd like to see a little bit more data. If you have a lot of tests, it'd be fun to compare, right? Mm-hmm. But I don't know for sure on that one. I think there's some rationale for it, as you've pointed out. It wouldn't hurt, perhaps, but it's something I think is a little bit fuzzy still.
Okay, this is for if you're not up to speed on this, there's some maybe fuzzy literature that maybe your yield is a little bit higher if you do the throat and then you do the nose. And in terms of grossness, I think that is the order you want to do them in, as opposed to the opposite. So that's what we've been doing for a little while. All right, let's go to Paxilvid. We'll get to the data thing in a little bit. So you made the point that it's maybe the second biggest scientific advance after vaccines. And I think you wrote recently, you came to understand the manufacturing process, and it's really tough. It's not like you can snap your fingers and produce a billion of these pills. So what did you learn about that?
Well, I looked at the molecule and, it's been a long time since organic chemistry, Bob. So I figured, well, it's got some fluorines in there, but hopefully it's a small molecule that could make the stuff, right? I found out subsequently, particularly from Derek Lowe, that it does involve not just a lot of steps, complex steps, because of these moieties in the molecule, which was published in Science by the Pfizer team. And, a couple of points. This was the first directed drug, not a repurposed drug, to be shown to be effective against the virus. So the structure was published, and I think the idea was, how hard would this be to make? And of course, Pfizer told back, last summer, they told the U.S. government it's complex to make. It takes several months to make a massive supply. That's why we need a big bet from you. So they didn't go to mass scale. But as it turned out, the rate limiting step here isn't necessarily the steps of the organic chemistry, industrial chemistry, but rather the materials, the raw materials, which mainly come from China, and they're of limited supply. However, now there's a Bangladesh generic company that's making Paxilvid. We don't know how they're going to be able to scale that, but they have gotten an emergency authorization to do that, and in India. So I think the production story, because of the rate limiting material issue, is a concern, and the fact we do have a very limited supply, and even the 80 million blister packs, the treatment courses that are promised by Pfizer by end of this year, seems to me, unless there's some surprises that come when we get wide scale use, it's very insufficient. That I wish we could get. If we had this in every medicine cabinet, wouldn't that be nice? In case you got a new diagnosis and you were starting to get some symptoms, you would essentially be able to abort the replication of the virus. It's not dependent on your immune response, which is really important. It shouldn't, no variant should affect it in the future, because it's dealing with Mpro, the main protease, which has only one mutation in it after 2 years. So it's not a region of the virus that's prone to mutations. So I think this, I called it a just-in-time breakthrough, because in fact, with Omicron, it couldn't have come at a better time. The short supply is what really is distressing.
And when it is in better supply, does it replace monoclonals? Does it just become the thing you do if you're an outpatient, you're diagnosed with COVID? And does it become Tamiflu that everybody takes it, or it still is you take it if you're at particularly high risk?
Yeah, really great questions. I think the supply is going to be the constraint, so we won't be able to have wide use. There are some issues, practical issues we can get into, but to me, for example, right now, we have a really serious healthcare workforce issue. If we had abundant Paxilvid, one of the other major features of this drug, because it hits the choke point of replication, that you get more than a 10-fold drop in the viral load very quickly. So, you could have, somebody, whether it's a nurse, a physician, clinician who gets COVID, and you could basically stop the transmission very quickly with a pill or a few pills, whatever. So that's another thing. Wouldn't that be nice to have in our armamentarium right now? There is a concern that if it has wide use, would we then select for, put pressure on the virus? I mean, I don't know how realistic that is, because this is such a conserved region. But I think it would be ideally the thing where you started to get some symptoms, or even, you potentially known exposure. I don't see the role of intravenous monoclonal antibodies. Right now, only one of them may work. The sotrovimab is the only one that seems to hold up against Omicron. But that requires an infusion. And then remdesivir is 3 days of coming back for infusions. Here you get the same near 90% reduction of hospitalizations and deaths with pills that are easy to obviously implement. So I see this as basically becoming the main go-to strategy. And if we had it right now, it would give us a lot more confidence to basically get through the pandemic.
Yeah, I see it exactly the same way. Is it known that it decreases transmission, or just we're extrapolating from the viral load data that it must?
No, the studies have been done, very good studies with not just viral load and copies, and yeah, more than tenfold reduction in both of the trials that were done, the high risk and the standard risk trials.
Great. All right, let's move. Well, let me ask sort of a couple other politically challenging questions. One is the schools. It's probably the hottest issue, and people are so passionate about it. How do you feel the schools have been handled, and what do you think about the schools now? Should they be open, or are there circumstances where you think it is reasonable for them to go virtual for now?
Well, this drives me a little nutty. The reason, I mean, most everyone I know wants the schools to be open. I haven't met anyone, except maybe a kid that doesn't like school, that doesn't want the schools to be open. So what gets me here, Bob, is that we have, of all the children in this country, you know, the 83%, the parents of these kids, 83% haven't had their kids vaccinated. 83%. Now, if there's a better way to keep schools open, besides having the teachers and the staff and the bus drivers and the kids all vaccinated, I don't know of a better way to do that. And here we are in this unique position of having abundant vaccines that are remarkably safe. I mean, the data for age 5 to 11, you just can't beat that in terms of safety. A total of 12 cases of myocarditis that were self-limited in 9 million doses of vaccines. I mean, help me. I don't know of anything that's as safe as that. Maybe even more safe than water. I mean, it's amazing to me. And yet we have all this made up stuff, to disinformation about children with the vaccine. So we have a way to get schools in really safe mode. No less, of course, with the mask and other the filtration, the better air quality, ventilation, all these other things. But the vaccines are the simplest way to accelerate safety, and we're not using them. And there are most countries in the world, the lower middle income, they can't even get vaccines, period. And we have these. We have FDA go ahead, and we're not doing it, and it's shameful, really. And I've got grandkids. I mean, my 7-year-old, soon to be 8, has had his 2 doses of vaccine, and his school is doing well. But I know, look, we are all well aware of schools that are shutting down all around the country, and this is a serious problem.
And you sometimes hear it, almost as in doctrine. The worst mistake we made last year was closing down the schools. We should never do that again. I assume there might be some point where you would say that you have to, right? Is that the way you think about it?
Yeah, I mean, the thing here about is not just the bonus effect of keeping the schools open by vaccinating children, but it's also the idea that what about these children networks with their families and all the other people they connect with? What about the idea that kids do get long COVID at a half or a third of the rate of adults? And then, also yesterday in the New England Journal, there was a new study that was in the teens from 12 to 17. It was incredible in terms of 98, 99% vaccine effectiveness against ICU, life support, need for hospitalization. There were 7 people who died in the study, teens, and they all were in the unvaccinated group. How much data do we need to be compelling? It's extraordinary. So yeah, all children should be vaccinated. And, it's amazing to me and depressing. We've even had to use the word mandates. Who would ever have heard that in prior times of this country? But this is part of our era today, and it's really sad.
Yeah. So you brought up long COVID. You've read the literature better than anybody around. What do you think the prevalence of it is? What do you think the prevalence is likely to be with Omicron, since it's probably too soon to know for sure? And how much does vaccination help you prevent it?
Really important questions. I wish we had all the answers. We have not had near as much of answers and definition about long COVID as we need. So as far as the incidence, obviously, in part, how you define it, when you make the call, is it after 12 weeks? and then the extent of the disability, but it obviously can be a major league disabling chronic condition. I have colleagues at Scripps Research with long COVID, young, healthy people who still have really serious problems in functionality. I'm sure you do at UCSF, Bob. This is a real deal. Maybe it's 10%, maybe it's a little bit lower, but it just depends on where you draw the line of not just fatigue, perhaps, but the mosaic of different symptoms. With Omicron, there's two ways it could go. We have no data on long COVID. We only made the diagnosis through the South African efforts of their biomedical community in late November. So, that was the beginning of the Omicron time, and it'll take months before we get a read on that. But there's a reason why we would think it could be worse with Omicron. And that is, first of all, we know most long COVID occurs with mild infections, some moderate. And so that's where the preponderance of long COVID occurs. And secondly, Omicron, because of its immune evasiveness, there's an important study today in Nature Immunology, which shows how there's persistent immune dysregulation 8 months after mild COVID infections in people with long COVID. So the point here is that if you have immune escape, this is the most immune escape we've seen by far of any version of this virus. It could make it more difficult for people to get over it. That is, ante up to the immune challenge, the antigen challenge. On the other hand, because it may have less tropism, we know that is a case for lung cells. We don't know about other organs, tissues in the body. You can make a case maybe it will be lower. But right now, we should plan for the worst about long COVID. And this whole idea of having millions of infections per day and it's inevitable basically ignores the long COVID concern. The last point you asked about is about, will vaccines be protective? As you know, Bob, there are a few studies now suggest that if you're vaccinated, the chance of getting long COVID is reduced, perhaps halved, perhaps a third reduced. I think that's still, we have no randomized trial data. It's a little bit tricky to make the call on that. I think that's still questionable. The whole immune side of this versus non-immune mechanisms of long COVID or their combined features is also, very hard to dissect out.
Mm-hmm. Yeah. I mean, what I find interesting is you hear all the time, I'm really worried about the long-term side effects of the vaccine. And I say I'm about 1,000 times more worried about the long-term side effects of COVID. Which I think you brought up that very well. Okay, let's talk about February, March, April. You've already made the point that we could find ourselves in a pretty good place. Cases coming down, quote, a milder virus around, more doses around of a really effective oral medication. But the questions then arise, the likelihood of a new and even nastier variant that wins the race against Omicron, the risk of reinfection, how well does your Omicron infection protect you against future infections, and more generally, how good is your immunity that you get from an Omicron infection? It feels like those are the two variables that determine whether we have just a good spring but a terrible fall, or a good spring and we're sort of out of this pickle. So how do you see those two things, sort of the risk of a new variant that's worse and how good the immunity you get from Omicron is?
Right. Well, these kind of questions led me over the weekend to write a Substack about, we're very lucky because we have so far our vaccine directed to the ancestral strain is held up amazingly well for severe disease hospitalizations against Omicron. That is, the 3-dose with the booster has 90% vaccine effectiveness against hospitalization. In fact, in the 65 age group plus, 94%, and after 10 plus weeks, dropping down to 89%. I mean, these are great data that from the UK, I think we're very lucky. The worry I have is that we could see a variant, that is probably hard to get one more transmissible. I mean, really, how are we going to see something more transmissible? But we thought that with Delta, and then came Omicron, right? But where I think the liability is in more antigen shift, more what we see of immunoscape that may evades our vaccines. Because if that were to happen, we're lucky, because if our vaccines weren't holding up, even 2 shots get you 50% against hospitalization. If our vaccines weren't holding up, we'd be in big, big trouble right now. Mm. But because we've got 62% of the American population vaccinated and 23% boosted, I mean, that's giving some Omicron defense, no less some of that prior COVID that helps as well. So we may not be so lucky the next time. And if there's one way to hurt us as a species with this virus, it would be immunoscape. And just because they have an Omicron specific vaccine in March, so what? You know, the point being is we could not have predicted this hypermutated Omicron. No matter what AI tool you have or human intelligence, these specific mutations that are littered all over the virus, not just in the RBD and the spike, but throughout the virus. No one could have predicted this. All the experts of virus evolution pretty much thought it would be a Delta plus. And then came this out of the, what a curveball, Omicron. So we don't know what's in store. And we have to be, truth telling about that. We could see a variant that's worse. And that is why, Bob, for a long time, Dennis Burton, our chair of immunology, and I wrote a year ago in Nature that we need a variant-proof vaccine. That is a pan-sarbecovirus or pan-beta coronavirus vaccine. And we haven't gotten all over that. That's what we should have in clinical trials right now. There is one from Walter Reed that's getting into phase 2, but we should have multiple candidate clinical trials, an equivalent of Operation Warp Speed, to protect us against a possible worse than Omicron variant. Then with that, and the treatments that are getting better, then we would have a whole lot more confidence in getting over the pandemic.
Mm-hmm. And you think that's feasible? You think that if we lean into this, it is scientifically feasible to find something that, because we didn't predict Omicron, but a pan variant vaccine would have been effective against it and effective against something that's even better than Omicron?
Yeah, that's a really key point now you're making. So there have been more than 15 broad neutralizing antibodies, BNAbs, 15 different reports from centers, mostly in the US, but some international. These are derived, these are treasure hunts in people, in the less than 0.1% of people that make these incredibly multipotent antibodies, sometimes directed against cryptic epitopes. The point being is that when they expose to Omicron, now that has been updated, they hold up really well. They hold up, because you're basically taking down the virus in conserved places. You're basically coming up with a way that should be variant proof, right? Because it's so broad and so potent, and it's made by humans. It's just a very rare, the rare people that can make these things. Mm-hmm. So basically what you're doing is once you find these BNAbs, you then reverse engineer a vaccine to make them. And you could make multiple BNAbs in a vaccine, right? The problem we have is there's no connection between the academic labs that are coming up with these BNAbs and showing their extraordinary potency, broad potency, with the vaccine companies that are willing to take the risk to make the vaccines that are pan-coronavirus. We don't have Pfizer, Moderna, J&J, any of these companies. They rather make Omicron-specific stuff. Yeah. And so we have no coordination. We have an NIH, consortium that just was, started with a few centers, but there isn't that kind of Operation Warp Speed where you get public-private partnerships, you take a big bet, you get into clinical trials, because the only way you're going to be able to tell if it's pan-coronavirus and variant proof is getting it out there. Mm-hmm. And showing that whatever this freaking virus, shows us that we can protect against it. So it's kind of like the comparison I'd make with the longevity pill. You don't know if it really improves longevity until you follow it for a while, right? Yeah. And that's kind of what a pan-coronavirus is. It's a challenging, but it's something we should be doing. It's a low cost, as we put forth in Nature a year ago, for what the bang that we could get out of it.
And then thank you. And then just in terms of if your immunity came from an Omicron infection, I'm guessing you're not going to get vaccinated if you haven't gotten vaccinated so far. Hard to believe that you're going to change your mind, although I hope so. How long and how robust do you think that's going to be? And how long do you think that's going to last, assuming that Omicron remains the major threat?
Yeah, well, like all your questions, they're really terrific. I mean, I think depending on what comes next, if it has even more shift, Omicron infections may not be protective. I think the key point here is the separation between, memory B and T cells and neutralizing antibodies. So the more you get vaccines, boosters, and infections, if you are unfortunate to have those, the broader your recognition is in your memory in B and T. So that will help for sure. But it's the infection part that is not the severe disease part, that's the liability, and then the spread that comes from these infections. So as you pointed out earlier, we're seeing a lot more reinfections of people with prior COVID with Omicron because of that alien antigen, if you will. And we don't know what this next one's, we're gonna have another variant, let's face it, right? Hopefully it would be something that is even less severe than Omicron. I try to avoid the term milder because it's taken the wrong way. But, we just don't know. And I think our best bet, knowing how many disappointments we've had and bad projections, is always plan for the worst, hope for the best. And I'm a very optimistic person.
Yeah, no, I know that. Maybe the last COVID specific question that I'm going to spend, we have a little bit of time talking about kind of what we've learned in the future of medicine. If somebody called you today and said, you can get your fourth Pfizer or Moderna shot right now, I don't know what you've gotten before, what would you say?
Well, I think there's a real important question there. As you know, in Israel, in people over 60, they're going forward with that. They're the first country that has done that beyond immunocompromised people. And we'll see data. I have to say one thing, Israel has been calling the shots right every time, even though it's been somewhat dissed by people at FDA and CDC at points along the way. So we'll see. But, if you're in a high risk situation and you're now 6 months past your third shot, and not so much that you're worried about severe disease, I think you're probably okay with that third shot for hospitalization protection. But if you're really worried about an infection and being pretty sick, that's where we don't know. And a lot of us in the healthcare workforce are getting to that point on the brink of protection, which really starts around 4 months, right? So I think this fourth shot in people of advanced age is a real question that we'll know the answer. Israel is great about getting that data out. And as long as we develop the trust in them, which they deserve, we'll get an answer probably in the weeks ahead.
So that's a good pivot to something you were beginning to talk about, but I sort of moved it along, but let's get back to it. Up until 2 years ago, you'd see a paper in a journal and it was from UK or from Israel or from South Africa and say, oh, that's not America. I'm waiting for the study to go. Whereas for the last 2 years, it seems like almost all of the insights, or many of them, come from studies from other countries. They have better data systems. They are investing more in clinical research. What's going on, and what do we need to do to be leaders in this area? Because it really feels like we're followers.
We are followers, and we have pathetic data systems. I mean, pathetic. And the one thing that really strikes me, Bob, is that, we of course support the current administration and, the fact that the mantra sticking to the science, but there has all these announcements from day one of taking on the administration through today. There has not been one mention of improving our data systems, not a mention. And this is just preposterous. Yes, we are forced to rely on other countries' data, but when these advisory committees for FDA and CDC convene, they basically, are unwilling to accept that data, even though there's not data here in this country. Because, like, for example, right now, we want to know these Omicron boosters, how well they're working to prevent hospitalization and deaths. And when do they wane? When does their protection, those people who are getting hospitalized who had a third shot, what's going on there? We were promised by the CDC in May that they would track every breakthrough hospitalization and death. Never happened. And so we don't have critical data. We have 150,000 plus people in the hospital. And I have begged at the HHS level that we have granular data on each of those people. Their vaccination status, which vaccine, when they got it, their age, their coexisting conditions, and all the basal stuff, right? And they say, we're going to look into it, even though it can be mandated by HHS authority. So we have, just a dreadful situation here where we don't have real-time capture of data. The only data that gets posted on the CDC is a month old, and it's de minimis about things like hospitalizations or deaths. And this is unacceptable. If you're going to go in a pandemic and try to deliver and guidance, you have to have data. That's how you develop trust. That's how you have the best navigation system. And we don't have it. But the most important thing to me, Bob, is there's no seeming will to get one. And that is distressing, and it has to change.
Why do you think that is?
Well, the main thing to me is that we have a secretary of HHS who came from California, the Attorney General. He hasn't shown up for the pandemic. Have you seen him? Have you seen him make a statement?
I saw him talking about how the CDC director doesn't have a degree in marketing the other day. That was interesting.
I see. Yeah, we have a serious problem. HHS, there's been a lot of infighting between the agencies, and the HHS secretary should be bringing that together. And so we have a serious problem. Is we have a no-show HHS secretary. We have an HHS that could mandate this data capture, but they're afraid, in my view, of political backlash. That's why they're not doing it. And you just can't. Yeah, we're a big country, but you know what? A big country without data is a horrible situation. So we have to rely on other countries. And, fortunately, we have amazing data that comes out of places like the UK and Israel and Denmark, South Africa, so many that has been terrific for us. But it's amazing. We have a different population here. We're much less vaccinated, much less boosted. We have lots of coexisting conditions that are not as prevalent in some of these other countries. And yet we don't have data. And I don't know. I mean, I don't think that the administration has delivered on sticking to the science, because part of the science is having the data.
Yeah, makes sense. All right, we only have about 7 minutes left. I want to sort of pivot to a little bit out of COVID and into stuff that you've thought about more deeply than anybody, which is sort of where the healthcare system is going, and particularly the digital transformation of medicine. I've sparred about this in the past because you've taken a relatively optimistic view, and I've taken one where sort of it's a little more bumpy. But clearly, COVID has moved things along. So, what are as you think about how the healthcare system is going to be transformed by technology and AI and all of that, how do you think COVID changed that trajectory?
Well, it certainly accelerated the telehealth story, which has been good to see. I think we're going to rely on that more over time, and that telehealth will go to 2.0 won't just be a video exchange, but exchange of real data, multiple types of data. So I think that's a good move. We have a long ways to go. The digital medicine revolution is still in the earliest stages. I'd say one thing that we're going to see a lot more of is doctorless diagnosis, screening. So whether it's things like we already have smartwatches that can pick up heart rhythm abnormalities, but that's going to extend to urinary tract infections, ear infections, skin lesions, and most of the common disorders that are not life-threatening. That's already getting rooted, and that uses, of course, the person capturing their own data, like what we've seen with a rapid test, or obviously from yesteryear pregnancy test, but also now algorithms, because these are more complex. They're not from chemical reactions. And so accurate screening is going to be something that's going to be big, getting a lot of legs. Virtual coaching for chronic conditions, and then ultimately to prevent conditions. We're seeing a lot of that diabetes, hypertension, and other things. So I think, AI combined with real world data, high frequency or continuous data, is going to be a very important movement in the next few years. But obviously, we have a lot of work to do to validate these algorithms and these deep neural networks that are transformative potential. But most of them are based on in silico data or are FDA cleared without the medical community ever seeing the data.
Yeah. And one of my worry when I talk to our faculty and ask about burnout, obviously COVID is probably number one. The second is the amount of stuff that's coming in from patients in ways that couldn't have happened before, whether it's data from their watch or mostly it's just questions or my magnesium's high. What does that mean? Or it says my EKG is abnormal. What does that mean? It feels like we're building the connectivity and democratization and more patient-facing systems, but then they still link to our legacy doctors and nurses and institutions, and it's sort of breaking them. So do you think sort of the future is there's just less of that back and forth because there's more things that can actually get diagnosed by the system so the patients don't need the old healthcare system? Is that the way this is going to play out?
Well, I think that's unfortunately how we're set up. It would be great if we had all this integrated. Other countries have been able to make that move, but we're stuck. But I think the combined effects of basically deep learning, both for the clinicians as well as for patients, has a decompression effect of being able to have restoration of the human connection in medicine, which obviously has eroded so substantially. If you go back to my old days at UCSF to now, it's unrecognizable in terms of what is the typical human connection in medicine. So I do think that giving empowerment to patients who are willing, and also on the clinician, helping them dealing with data, will make this a better form of medicine in the years ahead. And that excites me about where this can go.
Mm-hmm. Yeah. Yeah, me too. I think the question is probably pretty bumpy phase until we get there. And I think that's what we're all experiencing now. Eric, we only have a couple of minutes, maybe just last couple of reflections on sort of big lessons that you've taken away and or things that were particularly meaningful for you over the last couple of years.
I'm always learning a lot every day. I'm not sure. I mean, I think the pandemic experience obviously has been humbling to try to keep up with what's going on. The advances that we're making on the science, and then the lack of advances we're making on human behavior, and being able to counter the mis and disinformation, which has been stunning. I still remember that day seeing the first 95% efficacy from a phase 3 30,000 participant plus trial, thinking this is it, and basically we've ruined our chances by not having. So what I've learned is obviously human behavior and the power of misinformation and disinformation is far beyond what I ever estimated. It's more than sobering. And it's putting us in this current phase in a highly vulnerable position. I don't even know where the limit will be on hospitalizations and deaths in the next few weeks, because we're just so less prepared than the countries that have already sustained through their Omicron surge. So, I don't, the divisiveness, the politicization of the science and the mask and the vaccines and the boosters, I mean, all this has come as a shock to me, the extent of it. I mean, sure, every country has some of this. Mm-hmm. Nothing that I have seen to the extent as has occurred in the United States.
Yeah. Well, it's a sobering note to finish on, but it's obviously true, and you have done more than almost anybody I can think of who's to combat that and to put great information out there and make it available. And I'm grateful, and I know everybody who's watching is grateful to you for doing that, and I hope you can keep it up. It's been immensely helpful.
Thanks so much for having me and all the great work you're doing at UCSF. I'm always cheering for my alma mater there.
Great. Thank you. Thank you. Really appreciate it. Next week, we go back to a non-COVID topic, looking at the future and the present and the future of diabetes care. Thanks for tuning in, and stay safe.